let's just switch to radiopharms for a little bit. Something that is near and dear to my heart. Obviously Pluvicto is, I think that's one of the NCCN Category 1 drugs now, along with the Radium. Is that your go-to in patients that either now, of course, it's been approved in the pre-chemo space, but when do you use radiopharmaceuticals? Let's start with you.
Yeah, so pretty much a lot of patients, with the hormone-sensitive disease are on ADT plus the ARPI. When they progress, because you're following them pretty much closely at that point, you're catching them early enough that there's not a large volume of disease. And again, when you're thinking about older patients, I think it's very attractive to think of these radiopharmaceuticals, sort of the chemo-free
Targeted.
Yeah, targeted option. It's very attractive for the patients, and in results-wise, it's you get meaningful results. So oftentimes, a lot of patients would opt for that instead of cytotoxics.
And does the fact that in the Vision study, it was given post-chemo, there was a survival benefit, and granted there was a lot of crossover in the pre-chemo space, the PSMA-4 trial, but that one didn't show a survival benefit. And given that a lot of these patients, if they're motivated, are going to try to have everything, do you side with their wishes because I don't think a lot of people want chemo. If you ask them, do you want chemo or not, they're going to say no. But I guess my question is, do you kind of go back to them and say, well, you know what? Yeah, we could do the Pluvicto now, but you're also going to be getting chemo in the future because we want to try to, these patients, as Jose said, are not curable. We want to extend their life and keep their quality of life as high as possible. How do you thread that needle, Scott, in terms of chemo versus Pluvicto? Let's just use that as an example.
I'll kind of look at...
Which I assume you'd use Pluvicto over Radium. I think would you do that? Is that true for all three of you?
Yes, I mean, I think in terms of the criteria, it's going to be, less frequent than you find somebody that meets that criteria for Radium.
I'll probably look at tumor characteristics first, and their doubling time and volume of disease, and then their performance status. I think docetaxel is going to work pretty quickly and be able to handle higher volume disease. So if they're in trouble and we kind of need to pull them out, then I'll lean towards chemotherapy. If it's a slow PSA progression and that chemo seems a little bit like overkill, then I'll definitely try to use Pluvicto earlier. And some of it's just life timing, right? They have trips that they want to go on, or they have something and they want to feel great. So I'll use Pluvicto and be gentle, and then they can plan accordingly for the future.
Jose, your feeling?
So you know what?
Pluvicto versus chemo.
Pluvicto versus chemo, yeah. So, I tend to use the patient's values and their goals as a kind of a beacon, and then I try to maximize their goal, So if the patient tells me, look, I'm looking to maximize my life expectancy, so then I'm going to probably follow the data in that perspective, look at, trying to sequence based on volume, based on how rapidly things are progressing. If they tell me, that they have a particular preference for say, something that they perceive as curative, which Pluvicto is not, it's very targeted and it's very favorable, but then what happens after chemo, right? I mean, after Pluvicto, you have to look at that too, because it's a finite period of time. It's not a forever drug. So, making sure that they understand the limitations of these drugs. They're very good, but you want to make sure you educate them on the limitations. What are things that we're going to do after the Pluvicto, which will likely be chemo, And so just trying to make sure, but like to Scott's point, sometimes they do have, they want to keep their hair for that wedding, right? That, maybe they have neuropathy from diabetes and they don't want to go to docetaxel. And so I think all these things kind of help us, really sequence it. But I think if you're looking at the data from what we can see now, okay, is it seems that in those patients that are metastatic castrate resistant, right, that you're looking at extending their life, that they're probably better off doing chemo early on, right, and then doing the PSMA, the Pluvicto later, right. To your point, the PSMA-4 only showed progression-free survival, which is not overall survival. So if you're following the data, then you're probably going to want to do chemo first and then give them the lutetium later.
May I make a point that patients are often drivers of these things as well because they see advertising and they're chemo adverse and they come in and they really want to know. So maybe I'll have a discussion with them about these radiopharmaceuticals. Tell me what they are, explain them to me, is that an option for me? So I think marketing definitely drives this, too. Patients are aware.
No, it's a very good point, excellent point. And do you are also, I assume a lot of these patients, of course, they're mostly bone metastases. Most of them are probably on some sort of bone strengthening agents that you're...
Yeah, they're on denosumab or zoledronic acid, yeah. So, and I know you have to be mindful with those agents that you're using a bone strengthening agent.
And I'm just curious from all three of you too, as a radiation oncologist, someone who gives the Pluvicto, I see them coming back, every 6 weeks. But I'm curious on your end, long term, is the bone marrow suppression, is that a concern, I guess? And because a lot of these patients may be going to cabazitaxel potentially if they can handle it after. Do you see a lot of bone marrow suppression? Is that a concern for you in terms of the sequencing of these drugs or not?
I mean, after 4 lines of therapy, the bone marrow is pretty tired no matter how you sequence things, right? So it's always a little bit of a concern. The bone marrow suppression for Pluvicto doesn't seem to hang around that long after it's gone. During the cycles, it can be a little rough. And, I'll see platelet issues and things with chemo afterwards, but not typically low enough to delay treatment or need a transfusion or anything like that. Sometimes with Xofigo, same way, right? It's a little more challenging to deliver drug. But you do your best.
Absolutely. And Jose, have you found that after Pluvicto that you've been unable to give, let's say, cabazitaxel or something because of more of a permanent bone marrow suppression? I mean, the long-term data for these grade 3 and 4 toxicities are low, but they're not zero. Has that been your experience?
Yeah, and typically I'll tell my patients, it's all disease location because, with lutetium, it's all, targeted, right? So if I see a bunch of disease in the bone marrow and the pelvis, I'm gonna tell them, like, this may affect your bone marrow, and it's more than likely could have a bad effect. And I think if you probably parsed out the data and you took out those patients where they had pelvic involvement, then those are going to be the folks that have the profound, grade 3, grade 4 cytopenias. But I think that's the selling point, and I think it's a real thing, that it's targeted. So for the vast majority of people, if you don't have disease near the bone marrow, then your bone marrow is probably going to be pretty good. And I think in our practice, when we look at preserving the bone marrow, we want to preserve it, one, for quality of life for sure, but we also want to preserve it for future lines of treatment, and more importantly, for potential trials, right? Because if you fry somebody's chemo, and there's that life-saving trial that they can't get to because they don't have a bone marrow, then that's a problem. So we always want to make sure that we look at, their age, things that they can't control, because we know that older patients that have an older marrow tend to do worse. The disease location, and then the amount of disease line of treatment lines that they've had, and we want to make sure that we preserve that marrow at all costs.